of these cancers can be attributed to known risk factors. These risk factors include age. We know the general population is surviving longer, and the older you get, there is a higher chance of developing cancer. But importantly, there are significant environmental factors that predispose to cancers. Smoking, tobacco, excessive alcohol, eating processed foods such as processed meat, poor diet, overweight, obesity, exposure to sun, excessive exposure to sun radiation, pollution, viral infections such as HPV virus, other infections, and the ever so common sedentary lifestyle with limited physical activity is all thought to attribute to the increasing numbers of cancer in UK as well as the world. There is, of course, an element of bad luck. In UK itself, there is a 1 in 14 million chance of winning the national lottery jackpot, but the chance of developing one of the rarest eye cancers, choroidal melanoma, is 5 in a million. Why is it important to know these risk factors? Well, 4 in 10 of these cancers could be prevented by simply a healthier lifestyle. This is important not just for our patients, but also for ourselves and our families. This significant increase in number of cancers is not simply a problem of the West. It is an enormous problem that is going to develop, if it's not already developed, in India. It's thought that 1 in 9 people in India are at risk of developing cancers. People are living longer. It is thought that most Indians will live past 75. And just with the enormous population, I mean, if you compare UK population of 67 million, population of India is 1.4 billion. The number of new cancer cases diagnosed every year is huge. In UK, it was 375,000 a year, and in India, it is 1.15 million. So how are adult eye cancers treated in UK? In UK, as you know, we have a National Health Service with smaller cities and towns having district general hospitals and larger cities having teaching hospitals. All eyelid cancers are managed predominantly by oculoplastic surgeons in district general hospitals, teaching hospitals. More complex cancers such as orbital tumors are managed in teaching hospitals by orbital surgeons, and rare eye cancers such as ocular surface and intraocular tumors are managed in supra-regional centres at London, Sheffield, Liverpool and Glasgow. These cancers include uveal melanoma, intraocular metastasis, intraocular lymphoma, ocular surface tumors such as ocular surface squamous neoplasias, ocular surface conjunctival melanomas, conjunctival lymphomas, and other rare cancers. So why the need for supra-regional centers for these rare cancers? Well, it allows us to deliver the best care even for the rarest form of cancers. These services are nationally funded, so we are able to provide patients with the most expensive treatment free of cost. It allows us to give time and expertise to every patient. Every patient gets discussed at a multidisciplinary team to provide best possible treatment option. There is a group of nurses, psychologists, teams which will support our patients, help in counseling, breaking bad news. It allows us to act quickly, reduce cancer waiting times, treat the patient holistically, liaise with other cancer specialties if patients have, for example, metastasis, multiple cancers, or cancers which involve more than one region. It also allows us to maintain a robust database and allows us to follow the patients regularly, provide surveillance, it provides teaching as well as research opportunities, and being treated in a center of excellence means that the system is medico-legally robust. You know, mistakes happen, but we are able to minimize them by ensuring we have the best care possible in a multidisciplinary settings. It also allows us to compare outcomes. One important part of cancer care is to ensure that all centers provide the best outcomes. We have regular meetings with all the centers where we discuss our outcomes and ensure that we learn new technologies, learn from each other. We formulate national guidelines, and all this is possible simply by close liaison with the 4 supra-regional centers. Sheffield Local Oncology Service was established in 1987 by the legendary Prof. Ian Rennie. He was soon after joined by Paul Rundle, and I now lead the service, having been at SOOS for the. I'm going to. In UK, patients often see their opticians as the first point of contact, and if a suspicious lesion is noted, they're referred to the local ophthalmology team, and if there is a definite suspicion of uveal melanoma, the patients are immediately referred to the national cancer centers where we assess them holistically with various tools. We use the TNM classification to decide. Patients are then discussed at a multidisciplinary team meeting. Treatment modalities for uveal melanoma include ruthenium plaque brachytherapy, proton beam therapy, stereotactic radiosurgery, photodynamic therapy, or here's a slide describing in what situations we would decide what treatment. I'm not going to spend a lot of time on this. Plaque brachytherapy, applying, and really proton beam therapy. Again, complex planning is done and the patient's treated at Clatter Bridge with stereotactic radius is helpful in patients with enucleation. Well, PDT is used for very small. So in summary, over the last 10 minutes, we've noted that the incidence of cancer is reaching epidemic levels. There are risk factors that can be managed and may help reduce the incidence. Care of rare cancers and complex cancers is best in supra-regional centers. An MDT approach provides the best care for patients, while allows us to give a holistic care to patients. And really, it's important to take ownership by the oncologists, as ophthalmic oncologists, for these rare group of cancer patients. Not about just treating the lesion, but it's about saving their lives, saving their eyes, saving their vision. I believe